Another spectacular talk. Thank you, Olga. So now we're going to have a little question and answer session. If you have a question, there is a mic near you. Please hit the on button. It should turn green. Speak close to the mic. And then when you're done, please turn off because there can only be 4 on at a time. Um,
Since we live by RVUs, how is that impacting the quality of our work product? Obviously, people are taking shortcuts. They don't spend the time. They just try to get through as many cases as they can. And is this the bottom line is obviously malpractice suits, but that's like the bottom. Are malpractice suits increasing, and is the quality of the work decreasing?
Oh, so I personally, in our practice, I'm very resistant into providing RVUs to my faculty. I don't like to show it to them. What I will show it to them is kind of section-wide productivity level, and I usually would use ARAD for that, where we are. And I use RVUs to say, okay, if we're really high, we need to hire, right? But not in any other, or you're working too hard, or somebody who is way below, hey, you gotta do something. How can we help you to be more efficient? I know, that's not private practice model. I think before the malpractice suits, I think your reputation with your providers, with your referring physicians comes first. And so if they don't like your reports, if they have issues with that, we all know in our practices who is great radiologist, who is not. So yeah, it's hard. It's hard when you getting best at what being measured, and if your practice is focused on RVUs only, that's not going to work well long term, because that's going to be just the numbers, and everybody will want to do CTAs only, and that's it.
Does anyone want data? Okay, so to answer your question, it depends on the radiologist. The most recent work that I've seen done by Richard Ruckman, now in Florida, shows that some people read faster, others read slower. Mistakes happen when they are forced to work above their speed. Okay, so you've got your personal speed at which you're comfortable. If you're forced to work faster than you yourself feel safe, you'll be making more mistakes. Now, these data are, we don't have an answer to that. We do know that, for example, the average radiologist is going to read a chest X-ray and will glean 70% of all findings in approximately 20 milliseconds. 200 milliseconds, right? 70% in 200 milliseconds. We do know that false negatives, i.e. misses, happen like this. If this is, okay, so from your standpoint, this is time, right? False negatives will drop rapidly and then stagnate. At the same time, if you're looking at something for a very long period of time, your false positives are going to grow, and they grow this way. There is a soft spot. There's no such thing as looking at a study for a very long time with impunity. What happens is that at some point, if you stare at it for a very long time, you will have more false positives. There's another study that shows that people who read faster at their preferred speed are more accurate than people who read slower. All these studies are, I'll find the data for you if you really want to on request, okay? Now, which means we don't know why this happens. We actually don't know. We don't know whether people who are naturally less accurate will simply spend more time looking, or whether people who are naturally faster readers are more, we have no idea, right? But I've just given you data. The bottom line is this, that if you are being rushed past your speed, you will be making more mistakes. I do not have the data that malpractice suits are increasing. Again, this is correlation, not causation. You all could be making a lot more mistakes, but malpractice suits may not be increasing for a different reason, right? So okay, so I shut up now.
So, that's very interesting. And I think, having said that, and I agree. However, we have new rads, and if we don't push them to read faster, they will never be faster. And if you tell them that, well, you should be reading as you are comfortable, they will stay at 6 studies per day, right? So there is a soft spot. We need to train them. We need to give them tools of how to be more efficient. Okay, we need to, ideal situations, those fast readers need to tell them how they learn, how they made themselves that efficient, right? It's not that and again, that there is that group that is like, oh, if you're reading too fast, you're certainly missing something. No, again, if you're comfortable in reading fast, if you have the tools, if you have your efficiency tools, what is your search pattern that is very streamlined? What is your templates? If everything is aligned well, that you can read fast. And we need to give those tools to our new grads.
Starts in residency, really. Well, Rabaya is nodding. Yeah, we read a lot. They read.
So you had mentioned one of the solutions to our workforce problem was advanced practice, or might be advanced practice providers. But you also gave anesthesia as an example. But anesthesia currently with their CRNAs is spending a lot of energy fighting independent practice of their CRNAs. And that has been an issue, both concerns about safety and even more burnout for anesthesiologists and more demoralization and all of that. So what lessons, if we're going to now use and utilize more APPs in radiology, what lessons can we learn from that on the scope of practice battles and preventing that?
Great question. Great question. I think thoughtful planning for it, right? What can be done safely? What should require supervision? What are the training modules? What is the requirement for training for those things, right? CRNA is a 2-year program, okay? AA is a 2-year program. A lot of APPs that come to our practices and do paras and thoras, there's no special training necessarily, right? We teach them on the job, which, some of them do great things. If you talk to University of Michigan, they have APPs doing procedures for 20 years. And at this point, they're way better than most of radiologists. Okay. We're certainly getting there in a lot of places. So I think making sure that what their scope of practice, how it's defined, what's the training mechanism, what's the audits, what's the quality assessment for each one of them, what's the supervision, is they able to report things independently or not. I would say they have to report those things independently, because otherwise it doesn't really save us time. And again, phlebotomy is a great example, right? We need to define those things that that they are able to help us, and they do not require our advanced training of so many years.
Personally, I think that our worries about EPPs are, not going, are overblown. And the reason being is that, I think it's Waymo, right? Self-driving cars in San Francisco, and rapidly dropping accident rates. I'm hoping to see self-driving cars in the Taconic, which Rabaya and I serve all the time, right? Our trauma surgery will see decreases the way our bariatric surgery has dropped off the cliff because of Ozempic and company. We are going to see in the next 2 to 10 years such massive shifts with introduction of AI, right? That, we're talking about EPPs and they're taking our work. Let's just, Olga is doing best practices as they are now. Let's follow them. We really don't know what's going to happen in a year or 2 or 3. I think we just, there's so many known unknowns and unknown unknowns that we probably cannot give you an answer. And I think that the shifts are going to be so profound as to make our concerns here obsolete.
Thank you for wonderful discussions about workforce. And I couldn't miss the unspoken connection between workforce and wellness, right? Because really it was woven into everything that each of you spoke about. And just so you know, our chapter is going to be focusing on wellness we just formed a committee last night. So we're working on that. My question to you is lots of different valuable points. If you had to pick one thing for us to focus on as a community or as a chapter, what would you recommend for our one thing to do?
I don't know New York practice. So for me personally, ideally, everything should be focused on AI, proper AI implementation that would work both for practices and will be implemented well. Because there's just such a variety and we're losing so much time and so much money and so much effort and wellness without this implementation that is going to be just helpful to everyone and kind of ideally agnostic to vendors.
I do this for the APGR and sort of in the background. I think that the reason we are not feeling very well right now is because we are underinvesting. And we as a society, we as society at large, et cetera, et cetera. And if you were to focus on something right now, I would say find the point of investment into your members. Ask them what they need from the society. Focus on one thing that they will tell you, and then invest in it.
Thank you very much for your talk. I had a different question. I'm a national teleradiologist with 43 licenses, and I'm very familiar with the entire entrepreneurial scope of all these companies. And I work in New York in my home, and like Mount Sinai came to my house because they're behind on cases. Are big academic institutions interested in teleradiologists if they have backlog? Because independent teleradiologists are so used to producing efficiently with their own templates that it would seem to be a good match between the excess number of studies in hospitals that sit and the fact that teleradiologists are incentivized on a per-click basis to rapidly vacuum clean stacks. Or not, they're not called stacks anymore. Sorry, does that make sense, that question?
I like vacuum cleaning. Yes, but, okay. Always there is a but, unfortunately, which I was told I'm not supposed to use anymore. The problem is we want studies to be read, but we want them to be read to our referring provider satisfaction, right? And our referring providers want specialized, trained chest radiologists to read chest CT, specialized trained abdominal radiologists to read that liver MR, right? And they're getting very unhappy when we farm it out to somebody else or to other section members, let's say, abdomen helps and chest. They're like, this is not a chest radiologist. Why are they reading my chest CT, right? And so that's a big issue, right? And so the subspecialization and the ability to trust radiologists, even though it's all kind of, electronic, et cetera, it's still very important to our practice.
Thank you.
So you have a somewhat different practice here in Westchester. We are very big. We have 21% of our patients are unit patients. I think a couple of years back, we were second largest heart transplant center in New York State. So we are incredibly specialized, and our pulmonologist will not accept any reads except from a chest radiologist. However, there is a but. We use teleradiologists all the time. I talk to every teleradiologist who works for us. I check their work in the very beginning like a hawk because I'm now section head, all right? And therefore, I have relationships with amazing teleradiologists. Some of them we hire afterwards, and they work incredibly well for us, and we absolutely love you guys. But we screen and we choose and we work and we give feedback and we correct and we establish a relationship.
Thank you.
We have a question online. Victor?
Yeah, I just wanted to say it really depends on the practice. So I'm with Northwell, which is has both academic and community hospitals, and we actually hire a lot of teleradiologists, or at least in the last few years, we've added a lot more teleradiologists. Many of them on the West Coast, and they're ending up working sort of our middle hawk shifts, which are more like their day shifts. But we do, and we have a varied, amount of stuff that they can read. So some for the community hospitals doesn't need to be as specialized, and just really needs to be read, like most general radiologists would read. And then there's other stuff that is certainly more specialized, which goes to different lists, and they may not even see those lists. But we've actually hired some people out of academic practices on the West Coast who are quite specialized and read a lot of our high-end stuff as well. So really, it depends on the academic practice. We're so large that we can accommodate, radiologists of all manner of specialty. So that's it.
Flexibility is the key, for sure.
Question. So thank you for your phenomenal talks, very organized, very insightful. Just kind of going along with the same idea with, different practices with different skill sets, radiologists that work at different speeds and different demands. What's your experience or thoughts on having specialized individual lists that could potentially adapt with their speed, kind of add one or two more cases if their speeds are at different, going things like that? Do you have any insights?
I do it all the time, basically, right? I watch my lists. And for example, we have people who do MR and then help out in MSK, et cetera, et cetera. I'm constantly changing assignments, but you have to have somebody who's paying attention. You have to know, you have to be flexible, and you certainly have to know your colleagues, right?
You can try to do that. It takes a lot of manpower. Ideally, it should be, an AI solution to do that, to adjust. The one part that you're missing here is learning part, right? So if you put somebody who is good at knee MRI, they're not going to get better at shoulder MRIs, right? So it's pros and cons to each.
In the old days, before digital radiography, the doctors used to come down to the X-ray department to review the studies. The radiologist was sitting there and they went over the studies with them. Now they just go up to the nursing station, they look at the study, they look at the report, and there's no dialogue. Do you think that this is the most dramatic shift that I've noticed in radiology? Is there adequate communication now between the person requesting the study and the person dictating it? And how much more important is the report itself, because they're depending literally on the report and not a face-to-face discussion about what the radiologist thinks?
All right. Yep. There's a sea change in everything, in every a moment of our practice. The way my Tiger Text, which is the system we use for communication, beeps every 30 seconds, you would think I have adequate communication with my cardiologists and pulmonologists. Somebody calls me all the time. I'm constantly on the phone with somebody, Rabia will confirm, always talking to them, explaining. Another thing is it's so much easier to read a complicated case if you call and say, what am I looking at? And they give you a succinct summary. And, because we have Cerner, which is frankly a horrible system, right? And going through that medical record is difficult, where this is where AI is going to come in. It's going to actually, tell me. But right now we are communicating. Compared to our communications in the reading room 30 years ago at Columbia in this enormous ballroom. Things are different. But even there, communications were problematic because, for example, in those days, films were lost. And it took forever to look at comparisons because you didn't have it, etc. Now you can look at a comparison, it's never lost, and it comes to you from a different institution. So, yes and no. Things are different, there are different problems, right? And you know what? In our days, and yours and mine, okay, even sunsets were better, you know? But as new trainees.
I would say it's true and not true. I think with COVID, they certainly had no communication and it was very painful. But now after COVID, I have a lot of traffic in my reading room, a lot of traffic. And the physicians are coming back and they want to review images in person. If some of them, far away, etc., they will set up teams with me and they will review it. They all have their favorite radiologist and they will reach out. Your reputation is there. It's definitely came back. One thing that I want to say is that my younger faculty really wants me to have a single reading room back. We're working across 3 sites, not too far away, but 3 different sites. And they're like, can we at least have one bigger room where we're all together? The sense of community is very important. And it's, if you can bring it back, given, all the restrictions otherwise, you will be better off. There was one more question.
Yes, thank you. What's your take, or have you experienced any ideas regarding training pediatricians, recently graduated pediatricians, to do a 3-year fellowship in pediatric radiology, or neurologists in a 3-year neuroradiology fellowship, or I don't know, family medicine, sports in an MSK 3-year? So it would make like a comparable PGY6 training, but because there's, especially like in pediatrics, such a shortage on it, right? But then I had an attending that was a pediatrician that became a radiologist just to do pediatric radiology. So is that crazy?
I don't think anything is crazy these days. Literally. But it's certainly a great, interesting idea that can be explored. And what exactly are they missing from their training? You have to assess that and figure this out. My personal, anecdotal experience, one of my colleagues was in IR fellowship at the days where IR was not competitive, was internal medicine physician who wanted to do IR. He did IR fellowship first. At that days, it was possible. He went back afterwards and did residency, proper DI residency, and now he's again redid his IR fellowship, and now he's full practicing IR. So certain things happening, but I think re-looking at that would be ABR role to do that, and what kind of pathway would be for that.
The cardiology fellows in my institution do a training with me. We read concurrently with cardiologists. They are part of us. We have an incredibly collegiate relationship. And I train the fellows all the time. God bless. More. Give me more.
I'm sorry to cut this short, but we'll be discussing the same topics during the open mic session. I do think it's time for a break for coffee, bathroom. So we'll see everyone back shortly.